السلام عليكم أخواني وأبناء أطباء العيون. الموضوع الحالي هو تكملة لموضوع Management of uveitis Stepladder approach. هيكون حول Management of Presumed TB uveitis. The diagnostic criteria according to our local circumstances and the treatment of presumed TB uveitis. Iraq is one of the most TB affected countries in the Middle East region. TB uveitis is one of the most important infectious uveitis in our community, together with ocular toxoplasmosis and viral uveitis. Definite diagnosis of TB uveitis requires identification of the mycobacteria in ocular tissue or fluids, which is not always possible. Therefore, presumed TB uveitis is referred for cases clinically suggestive of TB, after exclusion of other differential diagnoses. The diagnosis is supported by investigations indicate current or previous body infection with TB. Manifestations of TB uveitis are probably caused by both direct mycobacterium infection and hypersensitivity reaction, and this is reflected on the management of TB uveitis. Diagnosis of presumed TB uveitis, according to the Stepladder approach for diagnosis of uveitis, consists of 4 steps. Step 1, history of present eye complaints. Step 2, ophthalmic examination, which is the cornerstone in the diagnosis. Step 3, systemic manifestations. Step 4, target investigations. Patients with presumed TB uveitis usually present with long history of uveitis, unilateral or bilateral. Sometimes inflammation of one eye starts months or years before the other. Diagnosis of presumed TB uveitis requires clinical picture probable with TB uveitis. This is the cornerstone in the diagnosis. Most important sign is choroiditis. Commonly multifocal, can be diffuse through the fundus or localized in the posterior pole or in the periphery, sometimes tracking retinal blood vessels. Serpiginous choroiditis is less common but highly suggestive of TB uveitis. Sometimes choroiditis associated with optic disc or choroidal granulomas. Choroiditis must be associated with one or more of the following signs. If more than one sign is present, the probability of TB uveitis is increased. First, granulomatous anterior uveitis with anterior and posterior synechiae, sometimes broad peripheral anterior synechiae, iris nodules, and iris granuloma. Second, vitritis. Third, retinal vasculitis, diagnosed clinically and with fluorescein angiography, preferentially venous, usually multifocal or segmental, with perivascular cuffing. Vasculitis in TB is occlusive, involving small or large retinal vessels, sometimes complicated with capillary non-perfusion areas, new vessels formation, retinal and vitreous hemorrhage. Presumed TB uveitis can be presented as retinal vasculitis or intermediate uveitis, without choroiditis or granuloma. This is probably hypersensitivity reaction to Mycobacterium bacillus. Vasculitis in TB uveitis is usually occlusive with the new vessels formation. Next step in the diagnosis of presumed TB uveitis is to exclude other differential diagnoses, whether infectious or non-infectious causes. Syphilis and toxoplasmosis are the most important infectious causes. Syphilis is relatively rare in our community. In suspected cases, positive lab investigations, VDRL and ELISA test can confirm the infection. Retinal toxoplasmosis can be presented as multifocal lesions, but only in immunocompromised patients or those taking systemic steroids without specific antitoxin drugs. Behçet disease is the most important non-infectious differential diagnosis. Behçet disease is non-granulomatous panuveitis with diffuse retinal vasculitis and retinitis, in addition to the presence of systemic criteria of Behçet disease. White dose syndromes are important non-infectious differential diagnoses. White dose syndromes are never associated with granulomatous anterior uveitis. Vitritis and retinal vasculitis, if present, are usually mild, and the lesions are limited to the posterior pole, rarely extend to involve the periphery. Sarcoidosis is very rare in our community. Patients with sarcoidosis usually have specific chest X-ray and CT findings. The diagnosis of presumed TB uveitis is supported by current or previous history of systemic TB, especially with incomplete treatment. Strong family history of TB can also be taken in consideration. Cases with probable signs of TB uveitis. The diagnosis can also be supported by one or more of the following target investigations. First, positive IGRA test and/or tuberculin skin test. Second, chest X-ray or CT for signs of active or healed pulmonary TB. In summary, the diagnostic criteria of presumed TB uveitis are: first, clinical signs probable with TB uveitis, choroiditis, choroidal granuloma, retinal vasculitis, or intermediate uveitis. Second, exclude other differential diagnoses. Third, the diagnosis must be supported with one or more of the following evidence of body infection with Mycobacterium tuberculosis: current or history of systemic TB with incomplete treatment, chest X-ray or CT for signs of active or healed pulmonary TB, positive IGRA test or tuberculin skin test, taking in consideration false positive and false negative results. Cases with a probable TB uveitis have clinical signs probable with TB after exclusion other differential diagnosis, but the diagnosis is not supported by any evidence of current or previous infection with Mycobacterium tuberculosis. Most cases of probable TB uveitis can be treated with systemic steroids and immunomodulating therapy in indicated cases without anti-TB drugs, while treatment of presumed TB uveitis requires anti-TB drugs and systemic steroids in indicated cases. Treatment of TB uveitis with anti-TB therapy consists of 2 months induction phase with 4 drugs: rifampicin, isoniazid, ethambutol, and pyrazinamide, followed by 7 months maintenance phase with 2 drugs: rifampicin and isoniazid. Management of TB uveitis requires adding systemic steroids in addition to anti-TB drugs, especially in the following indications: choroiditis involving or threatening the macula, severe vitritis, and severe vasculitis. Oral prednisolone 0.5 to 1 mg per kg is added shortly after starting anti-TB drugs and continue with a gradual tapering for a few months. The advantages of adding systemic steroids with anti-TB therapy are: first, decrease inflammatory reactions, macular edema, scarring, and epiretinal membranes. Second, control secondary vasculitis, which is probably hypersensitivity reaction to Mycobacterium bacilli. Third, control paradoxical reaction that may rarely occur after initiating anti-TB therapy, and probably reduce possibility of recurrent immunological uveitis after completion of anti-TB therapy. Management of the complications of occlusive vasculitis and new vessels formation is with scattered laser photocoagulation to the peripheral capillary non-perfusion areas before or shortly after the development of new vessels, and with anti-VEGF vitreous injections for secondary retinal or vitreous hemorrhage. في نهاية هذا السيشن تحياتي واحترامي للجميع.